Telemedicine refers to the remote provision of healthcare services using technology to exchange information for the diagnosis, treatment, and prevention of disease. Telemedicine allows for healthcare delivery across time and space and can greatly expand access or facilitate information exchange. Options like remote patient monitoring can help patients manage their chronic conditions. Remote ICUs can allow for care of critically ill patients at a distance while staff are time zones away and awake in the middle of the patient night. And telemental health can allow patients to access psychiatric consultations from the privacy of their own home. Telemedicine, however, is not without its faults. It works better as a substitute for some types of care rather than others. It's not so good where you need in-person interaction for surgical procedures or imaging or other interventions. And it may exacerbate disparities among patients given the different levels of access to broadband and computer technology. There was a decade of evidence that telemedicine could improve access to care. Nevertheless, there was low adoption of telemedicine for a few main reasons. For one, dedicated telemedicine technology was clunky, and the ability to use higher quality commercial technologies, whether FaceTime or Zoom or other platforms, was impeded by concerns about privacy and regulations. There were also other regulatory issues, such as licensure across states and whether physicians in one state could actually give and care for patients in another state. Second, doctors were resistant. It was not easy to schedule a telemedicine visit between and around in-person patient visits, and a single technical glitch that would take many minutes to resolve would sour physicians, nurses, and other clinical staff on the whole telemedicine endeavor. Physicians held off adopting telemedicine so as not to affect their current workflows of inpatient visits. There were also worries about malpractice and whether there would be coverage if you actually treated a patient in a different state and across different modes of delivery of care. Before the pandemic, few physicians had actually used telemedicine. Reports are that only 22% of physicians had used telemedicine on the eve of COVID in 2019. However, before COVID, there was a high level of willingness to use telemedicine, and that willingness to use telemedicine was growing. For example, in 2015, 57% of physicians said that they were willing to use telemedicine. That grew to 69% of physicians in 2019. But we should recognize that willingness to use telemedicine and regularly using telemedicine are very, very different. Telemedicine just wasn't mainstream in 2019 on the eve of COVID. There was another third barrier, and that is telemedicine did not work financially for most doctors, which made them a little hesitant. Governments and insurance companies were worried about fraud and abuse and the high costs, so they kept reimbursement for telemedicine pretty low, even zero. So prior to COVID-19 pandemic, only 6 states required payment parity for telemedicine. So for these 3 reasons, doctor resistance, regulation, and low payment, there wasn't a lot of adoption of telemedicine prior to COVID. But COVID and the pandemic changed the use of telemedicine literally overnight. Within 10 days, everyone had to flip. The data from the University of Pennsylvania's 5-hospital healthcare system on that change from in-person office visits to telemedicine is probably pretty typical of what happened around the country. Coincident with the first surge in the spring of 2020, in-person non-hospital visits at the University of Pennsylvania dropped roughly 50%, from about 300,000 per month to 150,000 per month. Concomitantly, with the drop in in-person visits, telemedicine visits increased to about 45% of all non-hospital patient interactions with the healthcare system. However, there was a very rapid correction. Within 6 months, by September 2020, total visits rose back to normal levels, but telemedicine visits dropped to only 13% of all non-hospital patient interactions. And frankly, telemedicine has remained at that same low level through the spring of 2021. So while we're using telemedicine more, it's not a lot more, even after the big surge in the spring of 2020. This overall experience with telemedicine because of COVID-19, I think, has two clear lessons. First, as behavioral economics reminds us, human beings are driven by inertia. But if forced, we can change, and we can change more substantially and faster than we thought possible. The medical system is no different. When faced with usual pressures, it will not change. But when there's an unusual pressure that forces change, it can change, and it can change substantially. Change happened because of COVID, and it happened much more rapidly and more extensively than was previously imagined with telemedicine. But rapid change only happens when the system is forced and has no choice. Many of the barriers to telemedicine because of COVID pandemic, such as privacy concerns and payment concerns, were quickly set aside once the public health measures made it necessary to substitute telemedicine for in-person visits. So crises can lead us to make intelligent innovations that allow rapid change. But there is a second message and second lesson that is closely related. That is, the healthcare system is kind of like a rubber band. It can stretch and adapt to new configurations, but it'll return to old practices unless the change is supported and structures are made to promote permanent institutional change. That means long-term changes, such as permanently integrating telemedicine into the provision of healthcare, requires making other adjustments, such as changes in the regulatory structure and changes in the payment structure. In the case of telemedicine, the kinds of structural adjustments we would need to make telemedicine more permanent and a larger section of the delivery of care include keeping temporary payment parity laws or introducing new payment parity policies so that doctors are paid fairly for telemedicine. In addition, we need some regulatory changes, allowing permanent transition to using services such as FaceTime or Zoom or BlueJeans for telemedicine consults. And we have to get over the regulatory requirements for interstate licensure so that doctors can treat patients across state borders. Temporary adjustments made by CMS and temporary increases in payment are not enough to fully cement telemedicine use. Adaptive responses don't necessarily translate into enduring changes, as we've seen. Entrenching telemedicine is conditional on payment and regulatory reforms that incentivize and reward the use of telemedicine in routine workflows. Internationally, we're seeing a similar rubber band effect. Countries had an explosion of telemedicines just like the United States right with COVID, and that too has subsided, either due to payment issues there, doctor preferences, patient preferences. But in some places, especially rural areas, telemedicine is likely to remain a large portion of care. Patients and doctors have experienced how much easier it is to hop on a video call than drive 4 hours to an appointment, and are unwilling to revert back to the previous system for routine in-person care. Despite a decade of evidence showing that telemedicine was a promising avenue for expanding access to care, there were multiple barriers that stood in the way of implementing telemedicine in routine care. These barriers, the attitudinal barriers, the technology barriers, the regulatory barriers, and the financial barriers, were largely overturned with the COVID-19 pandemic. As a result, given the inability to have in-person visits, there was widespread adoption of telemedicine, and it skyrocketed. However, without permanent structural adjustments to those barriers, the system will revert to pre-pandemic levels of telemedicine. If we want to institutionalize telemedicine as a larger portion of the healthcare delivery system, we have to address these barriers. Again, the technology, the regulatory barriers, and the financial barriers to make it more permanent.